Pengarah, State Pengarah of Negeri Sembilan, Dr. Arifin, Pengarah Hospital Tuanku Jaafar, Seremban, and yang berbahagia Dato, Dr. Professor M Balasegaram, my good old friend, and now a professor in IMU. When Mr. Vijay first rang me to give this memorial lecture, I was initially a little bit hesitant because the topic was about research. I'm not a researcher, I'm a clinician, but I do have some experience with clinical research in IJN. And because Prof Bala was my boss, was my mentor, and because he was an icon in surgery, I thought it was only appropriate that I should accept to deliver this memorial lecture. Even though his family members are not here today, I think they can be proud of him. He is really a giant in surgery and has brought the standard of surgery to a different level for Malaysia. Today, I'll speak initially about my experience with Prof Bala before I take you on the journey of how we introduced cardiac surgery in Malaysia and how cardiac surgery has developed over the years. When Vijay asked me to send a picture, I looked around, and this was the only picture that I had with Prof Bala when I was with him in the late 69 and 1970. And as you can see, Prof Bala was young, energetic then, and I'm glad today that Prof Kandasamy, who was my colleague and a friend during those training days, is here today. Prof Kanda, as you can see, is the same, he's upright, he's trim and proper. And breathing down his neck there was me, looking more like a Mexican bandit rather than a training surgeon. Of course, all the other trainees have become surgeons, but I'm not sure what happened to our Indonesian friend, Ahmad Nasution, who was also with us during that training. My association with Prof Bala started in the late 60s and in the 70s. I was a young doctor then, just came back from Australia and was posted to Johor Bahru, and I had a liking for surgery. But unfortunately, like many others, I was then sent to Kota Tinggi. So on my arrival there, the first thing I did was to write a letter to Prof Bala, because for every surgical training there at that time, it was a dream to work or be associated with Prof Bala, to work with him, or to have an attachment with him, or to have your name attached to one of his articles, many articles. So when I was posted to Kota Tinggi, I thought, well, why should I stay in this place for 2 years? I wanted to do surgery. So I wrote to Prof Bala, and he promptly replied and said that I must first complete my rural posting before I can come to GHKL. And so there I was, stuck in Kota Tinggi. But after I finished my posting, he was true to his word. He made arrangement for me to come to GH and work with him. And that's where I met Prof Kandasamy and all the other colleagues in that picture. I was not with him for long, but the period that I was with Prof Bala made a lasting impression on me. He was not only a great surgeon, he was an educator, he was a researcher, but one thing I noticed about him was that he did care very much for his trainees. He did everything for his trainees. Not only did he teach them how to operate, he taught them how to innovate, he arranged for them to go to UK, he found attachment for them because of his vast network. So he was very interested in the training of his surgeons. And I was fortunate then that he made all these arrangements while I was with him. My first experience with him in the operating theatre was soon after I arrived in Kuala Lumpur GH. I was operating with a registrar called Devanand, and we were supposed to do a thyroid. it was quite a big thyroid, and I was a junior surgeon, not quite a surgeon, trainee. And I had done very little thyroid in Johor Bahru. And obviously I was struggling with Dave. And next moment I saw this man breathing down my neck. He says, "What are you doing?" There was Prof Bala. And within minutes, he was scrubbed up and then took over the case. And within half an hour, the case was over. That was fast, that was quick, and it was a real surgeon in action. The next moment, I turned around to ask, he was gone. He had gone to his office to do more work. For us then, Prof Bala didn't want to waste any time. He operated, he went to his room, he innovated, he talked to educators, he arranged for us. There was no time to waste, so he was moving all the time. And we were very fortunate. During our time with him, he took great care to see that we finished our training. And he brought along an English gentleman, a retired English gentleman here, who taught us the Part 2 exams for the fellowship exam. And he was brought specifically, he was a urologist, by the way, specifically for us to have practice in clinical before the final exam. That was Prof Bala. He was an icon, he was a giant, and it was a dream for every young surgeon to work with him. And I was fortunate enough. And with that, even though his family members are not here, I must say they can be proud of him. He is a real towering Malaysian. Today, I will talk to you a little bit about my journey in cardiac surgery in Malaysia, and where relevant, bring up clinical research into the picture. I came back from Australia in year 1975, and as I said, was posted to Johor Bahru. And after that, came and worked in GHKL before we went to do cardiac surgery. I went to do cardiac surgery at the Brompton Hospital. And when I came back here in 1985, we had only one operating theater and 5 ICU beds to cater for the whole needs of the nation. Of course, you had a little bit of surgery, cardiac surgery done in GHKL, but in the University Hospital, but the numbers were small. In GHKL, we had a dedicated cardiology department and a dedicated cardiothoracic department. And because we had a cardiology department, there were many cases that were referred from all over the country. And over a period of time, you find that the waiting list was huge. We had 10 books of people coming, relevant patients that were requiring surgery. They were referred to Dato Zainal, who was the initial cardiologist, and he did the cardiac care, did all the investigations, and referred all these cases for surgery. And we just had to put them in the book. And we had 10 books full of names, patients with valve disease, valvular disease, with congenital heart, Fallot's tetralogy, VSD, ASD, PDAs, the whole lot. But we had only one operating theater, and we had about 5 ICU beds. And that was the first challenge. How do we manage this? It was difficult. And it was difficult ethically also, because we really had to play God. If we were to do cases according to the list, then it will block our ICU, and we can only do 1 or 2 cases the following week. So we had to select. We take the books, open the book, and say, okay, next week we'll do this coronary, this Fallot's tetralogy, this straightforward ASD. We had to have a mix so that we have a free flow through the ICU, so that we can do our 6 or 7 open hearts a week. To do anything, to do according to the list, would be to do the difficult cases which will stay in ICU, and we would not be able to clear the list. Even though we tried hard, Dr. Zainal had numerous patients coming from all over the country, referred to us for surgery. So that's how we managed. It was a real problem, we had to play God. But unfortunately, we did our best. Like anything else in life, of course, good fortune came to us. Not fortune means not money, but that time, somehow, we were referred a case that changed the whole face of cardiac surgery. Our leader, Dr. Mahathir then, had a heart attack one night. And he, like a true Malaysian, did not want to go overseas. He came straight to GHKL under Dato Robaya, and because of his chest pain, they diagnosed a heart attack, and they did a cardiac cath. And there he was, he had triple vessel involving the left main, which needed surgery. Being a true Malaysian, he decided that he must have the surgery in Malaysia. I've never met him and he has never met me. But he told the pengarah then, that was Dato Fonseca, can I meet the surgeon? And I happened to be the surgeon. And so I was called in. I was a bit nervous. And he told me, can you do this surgery? I can't say no because I had done some. But I said, all I could say was, yes, sir. I said, okay. Then you give me 3 days. I have to talk to Ghaffar Baba, he says, because he was the Deputy Prime Minister then. And then you operate on me on Tuesday. I reluctantly say, yes, sir. As I walked out of the operating theatre, of the cath lab, all the state pengarahs, all the DGs and all were there. And one of them scolded me, why did you accept to do the surgery here? I said, what am I supposed to do? I said, I don't do it here. So he said, why take the risk? Have you got enough facilities? Do you have enough staff? Do you have enough sutures? I said, look, we have done about 100 plus coronaries. So Dr. Mahathir, being a nationalist, could have gone anywhere in the world to have the surgery. But he did not want. He thought that it should be done in Malaysia by a Malaysian. So he put pressure on me. I went back to my room, and half an hour later, the DG then, Tan Sri Abdul Khalid Sahan, came and scolded me. He said, Yahya, why don't you call your boss? Let him do the case. I said, I'll be more than happy, sir, to do. He said, okay, you stay here. I'm going to tell the PM that let you call your boss and let him do the surgery. I said, that's great relief for me. Half an hour later, he came back and said, Yahya, you do the surgery, because he wants the Malaysian to do the surgery. I said, okay, sir. So the next 3 days of waiting was a nervous wreck for me. It was difficult because everybody rang, everybody queried about our ability to do bypass surgery, whether we have enough monitors, whether we had adequate staffing. But on the day of surgery itself, the morning of that, American cardiologist came, shook hands with me, and said, Yahya, I have to leave. But after the surgery, if you need medical asylum, you can come to US. I said, thank you. Well, the rest is history. Dr. Mahathir did well, the surgery went perfectly well, and that gave a boost to the Malaysian health standards and also to our fraternity. And with that, he promised that we should not be faced with such pressing problems like long waiting lists. And he planned that we should have a National Heart Institute. That's how the National Heart Institute came. Now, there were clinical problems when we had those long waiting lists. Now I will bring you a little bit about clinical cardiology. One, we had many cases, congenital hearts, that were born with symptoms. They were the VSDs, the ASDs, and the PDAs. They were the most common. Okay? These were left to right shunt. So at birth, these patients were symptomatic. The mother says they can't breathe. The mother said they don't feed, they were small for size. But as you all know, with the natural history of left to right shunt, as more blood flow through the lungs, you get pulmonary hypertension. And with pulmonary hypertension, there will be higher pressure on the right side. And with higher pressure on the right side, the shunting gets less. And what happens to the patient? The patient feels well. But you yourself, as a doctor, knows that actually the disease has progressed. So we have mothers coming with babies or with child and say, look, he was symptomatic before, he was small for age, but he's okay now, doc, you don't have to operate on him. He's all right, he's playing around. We know that even though he feels well, he's actually progressing in the disease. He has developed pulmonary hypertension, and if left alone, he will reverse the shunt. The mother, we had cases where the mother came and said, my son is now blue. Why? Because the right ventricular pressure has raised so much that the shunt has reversed. So we had so many cases like that who had reversed and were not operable. And the worst thing that a cardiac surgeon can do, and we had to tell the relatives, I'm sorry, your son has missed the boat, or your daughter has missed the boat. They come all the way from Terengganu, from Perlis, in vans, family bringing the child, and the child is blue. So those were the problems we faced with the long waiting list. There's left to right shunts which have reversed. Of course, these cases nowadays in Western countries, the treatment is heart-lung transplant. We don't have that service. So these patients, we see sad. They go back into the van, drive back, and we know that they will die. So that's one problem. The other problem we have was, as you know, rheumatic valve disease was very common those days. In fact, when you look at the statistics for cardiac surgery, most, 60–70% of our surgery then were valve problems. Now, rheumatic fever, as you all know, affects the mitral valve commonly and the aortic valve, mostly the left-sided valve. Now, the natural history of this, if you leave it alone, what happens is that they develop pulmonary hypertension. And when they develop pulmonary hypertension, then they develop right ventricular dilatation, and the right ventricle begins to fail. And what happens is that they will have tricuspid regurgitation. And with severe tricuspid regurgitation, we have then jaundice, pulsatile liver, and gorged veins. Those were cases we were seeing then. These were neglected cases. Long-standing mitral stenosis, long-standing aortic incompetence, with severe pulmonary hypertension, right-sided problem, tricuspid regurgitation, and pulsatile liver, and they come with jaundice. And you see them coming down from the taxi or from the vans that their parents brought them. And you know you can't do anything. We found out then that this type of cases, there's no point doing. They will die on the table with right-sided failure. So those were the other problems we faced. The other problems we face, that those who are operable are usually young female in the kampongs. Now these young girls are in the productive age. They want to have children. Now if you put a plastic valve, which can last long, they have to be on warfarin, anticoagulant. And we know that anticoagulant in pregnancy can cause bleeding. It has also been shown that it can cause a teratogenic effect. So we are faced with problems. What do we do with so many rheumatic fever cases coming? What do? Do we put a mechanical valve and let them go back to the kampong on warfarin, and then they get pregnant, and then they lose the baby, and they might die? Or we put a tissue valve. Now, a tissue valve is either porcine or bovine. Of course, in Malaysia, we try to put bovine valve, which is calf, from cow, rather than porcine. But it doesn't last, tissue valve doesn't last long. So what we did, we had a policy then. We had a policy where for young girls in the productive age, we say we will give you a tissue valve. You don't have to be an anticoagulant, but then you can complete your pregnancy, your family, but you must come back after you finish your family in 10 years. We give you about 10 years. You come back and we will replace that valve again with a mechanical valve. Of course, the second surgery is more risky. A second surgery in cardiac surgery is more risky than the first. It's harder. Everything is stuck. But that's our policy then. So we put tissue valves. But of the hundreds that we put, only a fraction actually came back with valve failure. Now, one thing about tissue valve is that when it fails slowly. So the patient gets symptomatic, then you have time to replace that valve again. And when we do the second time and put a mechanical valve in this 36-year-old female from maybe Dungun, we will at the same time advise tubal ligation so that they don't get pregnant when they get this mechanical valve the second time around. So those were issues that we had to face and faced so many of them. The young child with the left to right shunt that has reversed the mitral valve and the aortic incompetence due to rheumatic fever, who were neglected cases who have developed pulsatile liver and no longer operable. And we have this side of cases where the tissue valve failed and then they need a second surgery. Most of them survive the second surgery, but the risk of surgery is higher. We lose some, but the majority made it. But a large majority of those valves that we put never came back. I don't know what happened. They probably died in the village. Now, the cardiac surgeons of today see a different scenario. They don't see these neglected cases because we have finished them off those days. And they do get the occasional one. But it's important to note that the demographic of patients in those days of cardiac surgery is different from what it is now. So after the Dr. Mahathir's operation, he engineered the formation of IJN. So IJN was formed within 48 months on a turnkey project, Doctor. It cost 750 million. I had the opportunity to tell him that if we have a national heart hospital like this, and if we are still based on government salary, it's going to be a white elephant, because a lot of my surgeons were going to leave. It's so lucrative outside at those days. There were hardly any cardiac surgeon except Rosali. So he agreed that, okay, let's see whether we could do something else. So we decided to corporatize. By what corporatize means to turn it into a company, autonomous, but still owned by the government. So it was owned by the Ministry of Finance. And that, I think, was a mistake. It should be owned by the Ministry of Health. So it was owned by the Ministry of Finance. And so it was autonomous. We had a budget. And whatever government patients come, we'll just bill it to the Ministry of Health to such time when the volume so much that the Ministry of Health started to query IJN. Why did we want to corporatize? As I say, one, because we wanted to retain the experienced people. We cannot have a white elephant after spending 750 million. Secondly, we thought that being autonomous decision-making is fast. If we want to do something, it will be faster. Just like we want to introduce clinical research, we have our own budget. We don't have to wait to send to the ministry, wait for 3 or 4 meetings or processes, and then 3 or 4 years later get approval. Within 6 months, we developed a clinical research department. And within just 6 months, when we planned cardiac transplant, it went through the board. From the board, we had our own budget, and we did the first transplant 6 months later. So corporatization was good. Corporatization retained a lot of people. The only thing about corporatization was that there was a tendency towards commercialization. And that's where the Ministry of Health and the Ministry of Finance did not see eye to eye. Ministry of Finance thought that this is a company that should make money. Ministry of Health thought that this is a company which should help the development of cardiac surgery. But we did both. I'm happy to note that with IJN, we are able to train a lot of cardiac surgeons, and now we are able to open cardiac units throughout the country. When I first started IJN, my vision was by 2020, we should have cardiac services in all the countries, in all the states. And I hope we can achieve that. The other thing about being in IJN is that we have a tremendous volume. So it was a right place for training. Young people were encouraged to come, young doctors, take up cardiothoracic surgery, take up cardiology. And not only from Malaysia, every year we had Japanese trying to apply. The Japanese, because in training in Japan, you don't get much experience. After 5 years, you are still the third assistant retracting on the heart. Here, whenever I get changed in the morning, a Japanese trainee was there. He stood by me, boleh potong ini hari tak? No. He wanted to operate all the time. So we had to regulate it properly. But we had trainees from Japan, from Bangladesh, from India, everywhere, Indonesia especially. Until now, we have trainees coming. So IJN then became a place not only as for service, it's also for training and also for research. Because of the tremendous volume of cases, we could do research. And now the cardiology department and the cardiothoracic department take part in multinational trials. And we contribute our figures, our numbers to the international scene. Nowadays, cardiac surgery has changed, and changed because, as I said, the demographic have changed. In those days, we had valve cases. Nowadays, 90% of the cases are coronary surgery. And the coronaries that we are getting now are not like the coronaries of old when we first started. We are doing more cases in elderly patients. With age, you're going to have more concomitant disease. With age, you have carotid disease. With age, you have patients who had strokes before. With age, you have patients with diabetes. So the surgery is becoming more difficult. Secondly, with the advent of angioplasty now, we have patients coming in with a metal heart. That means the cardiologists have put 10 stents. We have not much place to graft. So now, there are now multinational trials going on to rightly put where cardiac surgery should be and where angioplasty should be. And the trials after 5 years now clearly shows the benefit of cardiac surgery, bypass surgery, over 2 or 3 stents over a long period. In fact, we were told that the multinational trials should stop after 3 years because the results show so much better with surgery. But of course, the cardiologists don't accept this. We have now to go through our society to bring out and expose these results properly. So, ladies and gentlemen, my experience, as I say, as a cardiac surgeon spans over 30 years. I'm glad that I've been able to contribute towards the development of cardiac surgery. But I must say that I learned a lot from Professor M Balasegaram. Not only as a surgeon and innovator, but someone who had no time to waste. He had everything. He wanted to do everything. He wanted to do research. He was an innovator. He taught. He operated. And I learned a lot from my time with him. And with that, I would like to thank the organizers for inviting me to speak on this second Balasegaram lecture. I'm also very glad that my old colleague, Professor Kandasamy, is right in front of me before I was breathing down his neck like a bandit. Thank you very much.
Thank you, Vice, and it's very motivating to all young doctors, especially in this hall today. Now we would like to call upon the State Health Director, Dr. Abdul Rahim Abdullah, who was accompanied by Mr. Maha up to stage for a token of appreciation to Tan Sri.
Now we would like to give a token of appreciation to the State Health